Well, thank you for the invitation to be here today. It's a real pleasure to be here. My name is Stefanie Green, and I'm a MAiD practitioner in Canada. And after hearing the wonderful speakers this morning, I'm ever more grateful to be working in the Canadian model that we helped create. It makes us feel very lucky and grateful, so that's wonderful. However, I'm not here to talk to you about the Canadian system today. I am here to answer that. And as I'm in Ireland, I thought I would do this by telling a story, of course. So in 2017, I met a man that I'll call Ray. It's not his real name, and this is not a picture of Ray, although it probably could be. Ray was not what most people would describe as an extraordinary man. His backstory was not especially complex. Our interaction didn't stand out to me as particularly special at the time. Ray was 62 years old. He'd spent 30 years as a commercial janitor. He'd never married. He had no children. Ray developed a lump in his right underarm, which he promptly ignored. And he then developed another lump on the left side and a smaller lump in the front of his belly. And new lumps began appearing weekly that were increasingly painful. But it wasn't until the largest lump actually broke through his skin and began weeping murky fluid that he decided to go see his doctor. And that was 14 months before I met him, and when he was diagnosed with metastatic lung cancer. So he had radiation aimed at the largest lump, which temporarily decreased his discomfort. But Ray later told me that whole time seemed a lot like he was playing a game of whack-a-mole, where he would treat one lump only to have 3 new lumps appear. So by the time I met him, Ray was thin and weak and covered in lumps of various stages of growth and breakdown. And he'd been admitted actually to the hospice unit 4 days before I met him in what was accurately described as a total pain crisis. He'd been asking for an assisted death for about about a month by then, and he had been in the hospital about 4 days before I met him, and he was still asking for an assisted death. Now, I suppose what is extraordinary about this story is that I'm standing here talking to you about this man who's asking me to help him end his life, and I'm suggesting that this man, or this situation, of course, is somehow not special. Because this whole notion of doing this work, and the work around assisted dying, when you think about it, is pretty extraordinary, right? So how does one even get involved in this work, and why would a doctor ever do so? So when I was, in 1992, I was 23 years old, and in my 3rd year of medical school in Montreal, and I had finally completed all of my courses in anatomy and physiology, and I was finally in the hospital interacting with patients, and also doing a required course in biomedical ethics. And in our class, we explored layered clinical scenarios, we discussed precedent-setting legal decisions. It was all very interesting, but thanks to a woman named Sue Rodriguez, there was a riveting and equally relevant story unfolding in the Canadian headlines, which many of you are familiar with. As many of you know, Rodriguez was only 41 years old when she was diagnosed with ALS, and after she learned what lay ahead for her, she hoped that a doctor would be able to give her medication to end her life when she felt the time was right, so that her death could be quick and certain. And she captured the attention of the world along with that of this young medical student when she asked a simple but powerful question. And of course she asked, if I cannot consent to my own death, who owns my life? Whose body is this? And I had never considered the notion of assisted dying before that. The more we discussed her case in class, the more certain I became, of course, that Rodriguez owned her own life. I mean, how could she not? And I began to wonder if that meant that she could do with it what she wished, even if that meant decisions that would cause harm, like smoking or drinking or taking drugs. And certainly most of my classmates thought so. What about the idea of taking her own life? Well, attempting suicide had been decriminalized 20 years earlier in Canada, so society seemed to maybe reluctantly agree. What about helping her end her life? So I began forming some opinions. And as many of you will know, of course, Rodriguez lost her fight for the right to an assisted death. But 24 years later, a very, very similar case was also making its way through the Canadian courts and unfolding in the Canadian headlines. And like many Canadians, I was following it closely. But for me, at this time, it was actually through the lens of a medical career. because at that point I'd been practicing medicine for 20 years. And I was married with 2 teenagers. I had a career I loved, a family I adored, a group of close professional colleagues I worked with. And during my training, the concept of patient-centered care had been ingrained in our teaching. Right? Essentially, we had been taught to help ensure that people's preferences, their needs, and their values were what helped guide our clinical decisions. I was taught this concept. I still believe in it. I like to say I preach it, I teach it, I like to think I practice it. When the Supreme Court decision came down in 2015, we knew assisted dying would be legal now in Canada. And I thought it was almost the perfect example of patient-centered care. It seemed to fit exactly the description I'd been taught. But I wondered who was going to offer this care. And I think I had in my mind the same questions that many doctors in countries that are currently considering legislation must also have in theirs at this time. Should I offer to get involved in this care? Do I want to consider providing assisted dying? Why would I want to do that? So at the time, I was working exclusively in maternity and newborn care. I was preparing women and their families for that transition that was happening in their lives. I was accompanying them through labor and delivery and then caring for their newborns. It was, as I frequently described it, the best job in the world. I mean, why would I contemplate making a change in my focus? Or did assisted dying even go against my professional obligations? I mean, isn't a physician meant to save and extend lives? That's what many people were telling me and thought. But I thought not exclusively. Because doctors help people diagnose illness. And when we're given the opportunity, we help fight the illness and promote wellness. But let's be honest, just as often, there's not so much to do. And when there's nothing left to do, our job is to stay present and to lend a listening ear and to answer questions for our patients so they can make the best decision for themselves. And as the expression, of course, goes, we cure sometimes, we care often, but we comfort always. And it seemed to me that the role of the physician was to help patients. And this actually really seemed to fit. The work around assisted dying, as I saw it, and I still see it today, is exactly that. We hear people's stories, we act as a resource, we explore and inform them about all their options, and then we try to empower them to make their very best decisions. Now, our new law was very clear. Nobody was obligated to do this work. Nobody could ever be forced into helping someone to take part in assisted dying. But after a little bit of thought and a little bit of education, I began to work in assisted dying. And I found myself in the most extraordinary of situations. I found myself sitting in front of people who were asking me to help end their life. And the work was, of course, intense and emotional, and full of this weird dichotomy, because in order to explore someone's wish to die, you had to simultaneously explore the things that brought the most meaning to their lives. And on the day of the death itself, of course, it was very sad and tragic often, because someone's life was ending. It's always sad. And at the same time, it was that impending death that was catalyzing some of the most extraordinary moments of beauty and love that I have ever witnessed. So there was this interesting dichotomy happening. And I would see that with children who were saying goodbye to their parents and with partners who were sharing their gratitude, to say goodbye to their partners of 50 years. And slowly over the course of the first year, I came to understand what drew me to the work in the first place, that intersection I'm so interested in between medicine and ethics and law, and why it was that I chose to continue to do the work. I think I'm supposed to be pressing this button once in a while. I've missed a few. Yeah, that's the paradox. There we go. Why do the work? So I'm frequently actually asked this question, why do you do this work? And the predictable, inevitable follow-up question about how I feel about it and how it has affected me. And I've spent a lot of time thinking of those questions. I can answer in sentences, paragraphs, or essays at this point. And that's really what I want to share with you today. I want to talk to you about why do this work. And the short answer is not quite as simple as it sounds, so bear with me. The short answer is simply because I can. And there's a lot of different meanings in those three words. So on one level, because I can means it's no longer illegal for me to do so, right? Canadians have evolved in the way they think about end-of-life options. Our highest court has acknowledged this shift in thinking. And as a physician, it is no longer a crime for me to help a patient who's suffering intolerably to end their life under very certain specific safeguarded circumstances. So I say that I can because I mean I'm allowed to do it. And on another level, I think because I can means that I have the skills to do this. I have some knowledge, I have some clinical experience. I'd like to think I've honed them over 30 years. You know, I spent 22 years practicing maternity care, and as many maternity docs have come to realize, there's an art to being the doctor in the room, the one who's supposed to be the knowledgeable guide for this great transition that's happening, the one who's supposed to help someone feel a little bit more in control of a very intense and very emotional day, one of the most important days in their life. Like labor and delivery is one of the most important days in someone's life. It's a time laden with family dynamics and intensity, and I am clearly not the most important person in the room when a woman is laboring in front of me. So there's an art to doing that well. And all of this is equally true at an assisted death. It's one of the most important days in someone's life. There's a great transition happening. It's intense. It's emotional. There are a lot of family dynamics going on in the room. And I am certainly not the most important person in the room. So while providing maternity care is this really joyful work most of the time, when it's bad, it's actually really bad. And so, like other doctors, over the years, I've also developed the skills to handle helping someone through some of the most anguishing moments of their life. And so I stand here arrogant enough to tell you that I think I have the skill set, which helps me answer why I do this work, because I can, meaning as a physician, I think I've developed the skill set over the years, and I'm able to do this work. But what I find just as interesting, actually, is that society has placed me and other doctors and other nurse practitioners in Canada in this very privileged position. It's quite unique, and you know, we've studied medicine, we've studied healthcare, and because of that, by virtue of doing that, society has somehow decided that we're trustworthy. It has somehow been concluded that we're honest, that we're relatively intelligent, and we're somehow respectable professionals, which is nice. Society has conferred upon us, rightly or wrongly, a certain authority, and we are considered safe. So as a doctor, I've been privy to some of people's greatest secrets, the fears that they share with no one else, that they don't share with their partners of 50 years, that they come to see me at their most vulnerable. This is the work of people in healthcare. And I've often caught myself wondering why they come to see me or why they trust me in these moments, and who am I to be counseling them in these moments and to be privy to such raw reality of their life. And I try to think that I hope that I've never taken this for granted, because to be invited into that space with someone and to help prepare them for that transition, you know, in maternity care, from that transition from person to family, and that wonderful event, what a privilege that was. And MAiD work, of course, is very similar, right? To be invited to share in someone's final journey, to really hear their story, and to have their trust in that time is, again, a very, very privileged position. So I do this work not so much because I chose to do it, which obviously is a certain necessity in that. I did choose to do it. But I do it because society and individuals, like the people I write about and like Ray, they have actually asked me to do it. They've granted me this work. They've given me that role. So how does that make me feel? Well, there's been a lot of growth and learning, and growth can feel a bit rocky at times. So first thing I did was I learned a lot about assisted dying. And I learned that people in Canada, at least, do not ask for MAiD due to a lack of access to palliative care. Correct slide. In fact, our data consistently shows that of all the people who've received an assisted death in Canada, almost all of them, 96% of them, have had access to palliative care, which makes sense because our law demands that we talk about options and include palliative care in that list of options. And in fact, almost 80% of people who've received an assisted death in Canada are already accessing and receiving palliative care. So that's not the issue. I also learned that the most common reason people ask for MAiD is not because of unbearable pain like Ray. That's actually very uncommon. We have excellent palliative care when we can access it. When people are asked to describe their suffering in Canada when they're applying for MAiD, they talk primarily of their loss of ability to engage in the meaningful activities of their life, the things that used to bring them joy and meaning. They talk about not being able to do their activities of daily living. They talk about their loss of dignity. These are the most common reasons and the way that people describe their suffering. So how does this type of knowledge make me feel? Well, it confirms that assisted dying is an important end-of-life option. It allows people to feel empowered and in control and sometimes able to make choices that best suit their own values, needs, and preferences, which means it feels very patient-centered, right? So it feels like I'm facilitating that empowerment, and that feels pretty good. Next, I learned about the power of collegial support. I kind of always knew it, but this really drove it home. The power of community. The incredible importance of having colleagues to learn with and to work with and to learn from. This is true in all areas of medicine and probably especially true in areas of controversy. So out of necessity, because no one should work in a vacuum, because nobody should work in fear and nobody should work isolated when you have a covered legal medical service, I helped to co-found the Canadian Association of MAiD Assessors and Providers, which is a national professional association that supports the multidisciplinary professionals that do the work of assisted dying in Canada. And I began this work with 5 other colleagues, 2 of whom I'm happy to say, Dr. Tanya Dawes and Dr. Ellen Wiebe, are in the room today. And I thank them for their help. CAMAP continues to do incredible things. This work has certainly taught me about leadership and about grassroots collegial support and the priceless value of a national community of practice, which we've developed. CAMAP does continue to develop a variety of educational opportunities to foster research, to encourage best practice, and I could say that I do what I do with this organization for the benefit of my colleagues across the country, but in truth, I do it just as much for my own sanity, because through this connection and this work and all that we do, what we are really doing is fostering professional resilience, and it is invaluable. So how does this work feel? To be honest, establishing CAMAP feels like it's been one of the most important things I've done in my career. It definitely inspires me to be the best I can be in my leadership, with my colleagues, with my patients, with everything I've done. And I think in a word, it has been quite fulfilling. And thirdly, I learned more than I ever anticipated about the media and misinformation. Yes, I'm from Canada. You've all read about us. We have seen a plethora of misleading information in the international headlines about what we do. Like this one. Man applies for assisted death as alternative to being homeless. Very popular story. I understand it made the rounds in several countries and is being held up as proof of the evidence of the evil that is being perpetrated in Canada, supposedly, about how somehow MAiD, rather than the poor resourcing of vital programs, is somehow harming those who've become marginalized in our society, the poor, the disabled, and the unhoused. What this particular story fails to mention is that this gentleman is quite likely not eligible to receive MAiD. As far as I can tell, he has actually not been seen or assessed by a MAiD practitioner. No one with experience in the work has told him he is or will be eligible for MAiD. The story does say that he's been told he's eligible for MAiD, but it turns out he's not seen an experienced MAiD provider ever. So, more importantly, however, not just the half-truths that are in the story, more importantly is that if unstable housing is his motivation for assisted dying, he actually doesn't qualify under Canadian law. Anyone can actually ask for an assessment, but assessment doesn't equal eligibility. It's actually a lot more rigorous than that. It's a lot harder than most people realize to qualify. So that's just the truth. But there are unfortunately many more examples of misleading stories and videos, one-sided and incomplete reporting. I know you have seen those headlines. There are far too many to try to tackle here today. But I can tell you, how does this make me feel? This kind of misinformation that we read, that my colleagues from around the world call and ask me about? Frustrated. This is not the best of what we're doing. Legitimate questions should always be asked. It is important we do this work to the highest of standards, but half-truths and blatant misinformation help no one. Eric Matheson, who's speaking after me today, who I suggest you read if you haven't been familiar with his work, because it's excellent, He has a number of excellent articles on these issues, and in a recent bit of writing of his on anti-MAiD arguments in general, he outlines what he sees as the 3 stages of the evolution of arguments against MAiD, against assisted dying in general. And he talks of the first stage being in opposition to MAiD itself. And in Canada, our courts have kind of taken that out of the equation. He talks about the second stage manifesting as opposition to the effects of MAiD. And here's where suggestions that homeless people or disabled are somehow being forced or dragged to apply for MAiD. And I assure you there is no evidence for that at all. And the third stage is one that he sees us entering now in Canada, and I unfortunately can concur. The third stage of anti-assisted dying arguments, which are now surfacing, are primarily focused on attacking the moral character of the care providers who do this work. Do we remember Ray? His radiation and chemotherapy were not successful. He'd been admitted to the hospice in a total pain crisis, and his palliative care doctor was increasingly frustrated as all of her efforts were not proving as useful and as successful as she had hoped. When I finally met Ray, he was sitting upright in one of those soft recliners. His eyes were closed, his feet were planted, and he was grabbing onto the armrests of that soft recliner. There was, although there was a eucalyptus aromatizer on the bedside table next to him, it was no mask, it was no match for the unmistakable smell of rotting flesh that pervaded that whole room. And he told me he was sitting so rigidly because even breathing was painful for him. He was in a terrible state. And I was able to tell Ray after our assessment that he was eligible for MAiD, and right away after my first visit, and he actually planned to proceed quite quickly in a few days. So Ray's death was a simple affair on the rooftop in the garden, actually on the rooftop of the hospice building that he was admitted to. And he was accompanied by 3 of his close friends who he thanked for being with him all along his journey, and they wished him a safe and comfortable journey wherever he was going. And then just before I was about to administer the medication, Ray actually grabbed my hand in both of his, and he looked me in the eye, and he said, "I know this is going to sound ridiculous, Dr. Green, but I think you saved my life. Thank you for making this happen for me." And those were his last words. So you ask me, how does that make me feel? Well, it caught me by surprise, actually. But afterwards, when I really thought about it, I felt kind of good, right? And I didn't think I could tell anybody that, because here I was helping someone end their life, and I was kind of feeling good about it. But more accurately, I was feeling like I had done something good, like I had given a dying wish to a dying man, like I had fulfilled that wish for him. And I wrote honestly about my reflections on this experience in my book, and MAiD opponents have now used these reflective thoughts to attack my moral character. However, the work of providing assisted dying feels important. Why do I do this? I do this because I can. I do this because I'm allowed to. I do this because my training and my experience has taught me the skills to deal with these situations with what I hope is a semblance of grace. Because society has honored me with the power to be the person that people come to ask for this care. Because it is part of my role as a physician, to help people. And I really believe that to be invited into that intimate space with someone and with their loved ones and to help them facilitate their final wish is a privilege, and the work itself turns out to be profoundly meaningful over and over again. I am not suggesting that every doctor needs to do this work. I'm relaying my personal experience, and you can take from it what you wish, but the follow-up question wasn't really how do you feel about it, it was more about how has it affected me. So before I end, I need to mention that I have grown not just professionally, but I think personally by doing this work, because it is impossible for me not to project myself into all the situations and the environments that I witness and that I see. And it's impossible for me not to ask myself, what would I do myself in that situation? Would I have made the same choice? Who would I want holding my hand? What music do I want playing? And I challenge you to think about who you would want with you when death is near, or when you know death is near, and why you want those people with you. And have you told those people recently how important they are to you? Have you spoken to them recently? Because since the beginning of this work, I am much more reflective of the people and the relationships in my life. How could I not by doing this work? So through this work, I'm convinced I've become a better doctor, a more compassionate doctor, but I think more importantly, I think I've become a better person. And given all of this, I think maybe the question that's most important to be asked is not why I do this work, but I think maybe the question ought to be, why wouldn't I? Thank you for your attention.